Afternoon to all. We are back with yet another Master Series webinar with our expert on board. I have the distinct pleasure to introduce our speaker for today. We have with us Dr. Jayaka Thomas, who's currently the Emeritus Professor at Dr. MGR Medical University in Tamil Nadu and also the Professor of Dermatology at IMA New Delhi. He has previously held office as a National President for IADVL as well as the Indian Society of Teledermatology. He has been in the field for more than 40 years now, and with this wealth of experience, he is also a sought after speaker for many conferences. And we are truly lucky to have be able to hear him today on the topic of atopic dermatitis. Dr. Thomas has been awarded the K.C. Kandari Foundation Award Lifetime Achievement Award for teaching, practice, and research in dermatology. Apart from this, he has also bagged many national and international awards in his name. At Docplexus, he has also been helping us and guiding us as an advisory board member. We are excited to have you on board, sir. Welcome to Docplexus Master Series.
Thank you, Darshika. Is my screen visible?
Yes, sir.
Right. Good afternoon, everybody.
So we can't see the presentation. It's on the Gmail, I think you've logged in. If you could just share your screen again. I think it has gone to...
Now?
Yes, sir. Perfect.
Sorry for that delay. Anyway, thank you again, Darshika, for those nice words of introduction. Good afternoon, my dear friends who are here participating in this seminar today on atopic dermatitis, optimizing outcomes. A little information about myself and my disclaimer. Now, what is atopic dermatitis? The definition, of course, always I love to start with a definition. A common chronic inflammatory skin disease characterized by intense itching, dry skin, inflammation, and relapses. There's a tendency to form high levels of IgE to very common antigens, house dust, mosquito bites, and things like that can lead on to high levels of IgE. Now, eczema, atopic eczema is the most common chronic relapsing inflammatory disease in pediatric dermatology. Pediatricians see it more frequently than other specialists. The pathogens of eczema may be closely related to inheritance, immune disorders, epidermal barrier impairment, and environmental factors, of which I will be telling you very soon about the most important pathogenetic factors. Now the topic, optimizing outcomes, If you take up Webster's dictionary and look at the meaning of optimizing, to make management as good as possible to the best level that is available, so as to increase one's confidence in one's ability to incorporate atopic dermatitis treatment strategies that use patient-specific and patient-friendly factors. And that's what exactly is going to be discussed today. Now, I have spent extraordinarily long time in the field of atopic dermatitis ever since I had post-graduated 1982. Seen several agents approved and in development still in the treatment of atopic dermatitis. I've been seeing updates of these in some of the recent conferences, discussing some of the data and discuss how these data may be affecting clinical practice. Now, to look at it fully, atopic dermatitis till about the year 2006 was thought to be an allergy-dominant skin disease. Everybody was talking about antigen-antibody reaction, anaphylactic reaction, type 1 hypersensitivity. But after the year 2006, it became more of a barrier-dominant disease, and I shall tell you how. There's one thing which is known as a filamentous aggregating protein, or the filaggrin, which gets mutated in children and in patients with atopic dermatitis or atopic disease of any form. It could be eczema, it could be asthma, it could be hay fever, it could be urticaria. So any of the atopic diatheses where it gets dose related. If both parents have a filaggrin mutation, there's a 100% chance that the child is likely to develop an atopic manifestation. Allergen penetration becomes easier. Decreased natural moisturizing factors. Again, I shall elaborate shortly on this natural moisturizing factors. And peeling of the skin resulting from loss of the corneodesmosomes, that is, the bridging gaps between the cells in the uppermost part of the epidermis, namely the stratum corneum. This is what I told you, the uppermost part of the epidermis, the stratum corneum. The next layer is the stratum granulosum. What happens to this? What happens to this? Just now spoke about filamentous aggregating proteins, which are normally present and which are not mutated. But once there is a destruction or mutation of the filaggrin fibers, which we shall talk about later, now, as long as the filaggrin is normal, the stratum corneum can function both structurally with a lot of integrity, changing with climatic changes, ambient humidity, use of poorly formulated or irritant skincare, other products, overwashing and exfoliating skin procedures. And that's why the stratum corneum is described as the biosensor detector. It can detect a lot many things, and the most important of which is increased transepidermal water loss, loss of water in stratum corneum water content, and disruption of the physiologic stratum corneum water gradient. Now, what happens when there is a mutation? The epidermal lipids, which are already present there, namely the ceramides, the free fatty acids, and cholesterol. And I told you, I'll tell you what the natural moisturizing factors are: urea, lactic acid, and pyrrolidone carboxylic acid. Here I've just mentioned it as PCA, pyrrolidone carboxylic acid. Now, when filaggrin mutation occurs, everything is reversed. All this biosensor activity of stratum corneum goes away, the epidermal lipids are lost, the natural moisturizing factors are lost, and the skin is left in a situation where there are so many gaps, through which things which should not normally go out from the skin, namely water, and things which should not normally come into the skin, namely microbes, can be doing what they should not be doing. And depending on the severity of the filaggrin mutation, the more severe, more persistent, more skin infections, more environmental allergies, as obviously shown in the previous pictorial depiction. Now, apart from this filamentous protein aggregating, which gets mutated, this can lead to a lot many complications. It's a very busy slide. I don't want to go through this entirely. On the other hand, I'll tell you that the story does not end with filaggrin. It goes on to affect the junction between the cells. I told you the junctions get lost, particularly when we talk about different junctions between cells in vertebrates. There are different types of junctions. But here in AD, in atopic dermatitis, tight junctions are what we're looking at. Now, what are these tight junctions? These tight junctions are those that fill the gap between the cells of the stratum corneum. That is, they are made up of two types of proteins, claudin and occludin. Now, claudin is one thing which can really protect the intercellular spaces, and occludin will occlude the space, any space. That is, in other words, what we always tend to call as the brick and mortar system of the stratum corneum. Now, what happens? Now, these tight junctions, which I spoke about, namely your claudin and occludin, which are found here, they have two surfaces: the upper surface of the epidermis, the apical surface, and here is the basal surface. To elaborate further, the apical surface and the basal surface of these tight junctions. Now, when the tight junctions are intact, they do not allow any external material, particularly microbes, to enter into the skin. They block them. At the same time, apart from blocking something from outside to inside, it also does not allow the water content from inside the skin to escape out. That is, there is no transepidermal water loss to a great extent. Some amount of water is lost. You and I lose water through the epidermis. But there's not a huge, big amount of water loss taking place because of the presence of these tight junctions. Whereas when these tight junctions are absent, as what happens in atopic dermatitis, these things go haywire, microbes come inside the skin. That's why atopic skin is so much prone for infection, superficial infections. And it does permit water in a big way to get out of the skin. That is increased transepidermal loss, water loss. That is why there's so much of xerosis or dryness in the atopic skin. However, the story doesn't end with filaggrin and tight junctions. As I told you earlier, initially atopic dermatitis was thought to be an allergic disorder, an immunological disorder, and that still holds good. It still holds good. Here is a diagrammatic representation showing the epidermal dysfunction resulting from inflammatory reactions. Now, if you were to separate that diagram, I show you the filaggrin, the Langerhans cells, and the Th2 cells, Th2, not the Th1. Th1 are associated with another very important skin condition, namely psoriasis. Here is the Th2 cells. Now, what happens is with the interaction between filaggrin, Langerhans cells, and Th2 cells, the production of interleukins, particularly interleukin 4, interleukin 13, as well as interleukin 31. Now, from there on, there are the possibilities of three things happening. One is they can start producing what is known as TSLP, or the thymic stromal lymphopoietin, which allows inflammatory effect to increase. More of cytokines are released as soon as TSLP enters the stratum corneum. The next possible thing that IL-4 and IL-13 can do is have an effect on the Th2 cells, as well as the mast cells and the eosinophils, leading on to the production of IgE, what we saw in the definition of atopic dermatitis. And the third possible thing is its effect on antimicrobial peptides. It inhibits the antimicrobial peptides, leading to more and more infectious entering into the skin. Now, there's yet another newer aspect of atopic dermatitis pathogenesis that has come: oxidative stress. Oxidative stress. And you find that there is a cycle here, a vicious cycle: allergy, immunology, skin barrier abnormality, pruritus, all associated, the center of which is oxidative stress. And how is this all going about? Much of what we know about atopic dermatitis, the pathogenesis of atopic, revolves around fundamental concepts of barrier dysfunction, which we spoke about, inflammation, which we spoke about, and dysfunctional immune response, which we also spoke about. Dermatologists often give advice concentrating on moisturizing, bathing, cleaning, reducing symptoms of itching and dryness of patient AD. However, my dear friends, a recent observation in atopic dermatitis research is that oxidative stress plays a central role, as what we saw in the previous figure, a central role in the pathogenesis of this chronic relapsing skin disorder. Events that lead to skin barrier defects have also been correlated with the release of reactive oxygen species. We call it as ROS most of the time, reactive oxygen species, which directly damage the skin's cellular components, such as the cell membrane, the cell organelles, and even the DNA. So, having said that about the pathogens of atopic dermatitis, let us look at how we can diagnose atopic dermatitis. Of course, we have no gold standard test for the diagnosis of AD. Laboratory test. It's not easy at all We don't have some easily available lab diagnostic procedures. So we have to depend on clinical diagnosis only. Severe pruritus, a classical morphology, typical distribution of the lesion, positive family history. Way back in 2005 itself, this was discussed in the British Journal of Dermatology, where they said that if all these four are present in a particular child or an individual, one should think of a clinical diagnosis of atopic dermatitis. All the while, there were markers like, for instance, absolute eosinophil count and serum IgE levels. They were thought to be useful laboratory markers of atopy. This is no longer tenable, ladies and gentlemen. More recent biomarkers include serum thymus and activation regulated chemokine, what is known as the TAR, thymus and activation regulated chemokines. Then we have one thing known as the CTAC, cutaneous T-cell attracting chemokines, and the SSCA, squamous cell carcinoma A. Now, many of these studies have been concluded to validate biomarkers. But the most important aspect of this is not easily available in our country and not available in all centers in our country also. There are hardly half a dozen centers who are able to do these laboratory tests, which can really be useful not only for diagnosing, more importantly, when the patient is being treated. These levels come down drastically, which helps us to know whether our treatment is really helping the patient or not. Now, for convenience, generally, we divide clinically atopic dermatitis to mild, moderate, and severe. Now, this is not done just at random or just for the heck of it. It's done specifically keeping the treatment in mind. Because as long as there is severe atopic dermatitis, oozing, severe oozing, patient is not able to sleep, child is always complaining of itching and infection, we have to go for oral rescue medications. And what are the oral rescue medications? Oral rescue, I'm not talking about the biologics. Now, oral rescue medications include particularly cyclosporin, methotrexate, oral steroids, all this can be used, will have to be used rather. Whereas in the moderate forms, may have to use a topical calcineurin inhibitor with topical corticosteroids, super potent corticosteroids. And as the level or the severity of the disease comes down, we also bring down the potency of the topical corticosteroid from a super potent to mid potent. And thus far, having controlled it, when it comes to the mild stage, maybe a topical calcineurin inhibitor, your tacrolimus or your pimecrolimus, really helps in this situation. And most importantly, when in a child, topical corticosteroids are beginning to show the adverse effects, atrophy of the skin. That's the time when we'll have to make use of a non-steroidal anti-inflammatory agent. All anti-inflammatory agents, steroid being one, non-steroidal anti-inflammatory agents being the topical calcineurin inhibitors. But basically, you can see from this diagram, whether it is severe, moderate, or mild, what is important or what are important are the different forms of moisturizers. So moisturizers all the time will form the basis of the management of atopic dermatitis, whether mild, moderate, or severe. This is a different representation of the same thing what I showed earlier. Oral rescue medication, acute forms or the severe forms. Less severe forms keep using the potent steroids, mild potent steroid, topical calcineurin inhibitors, again topical calcineurin, finally moisturizers, which will come throughout. This is another boxed way of putting it. Now let's go to something which we started off with the title. What is optimizing it? So the options before 2017 were a number of them. If you look at insightfully from the expert point of view, we had prednisolone, cyclosporin, methotrexate. Methotrexate is a very important drug. It's a poor man's cyclosporin. The methotrexate, azathioprine, mycophenolate mofetil, all these are available. Now, why we have to start looking at them from different angles, from and expertise, insightfulness. Methotrexate, long onset of action. You have to wait at least for 8 weeks before it starts acting. Cyclosporin, within a week or 10 days, you'll find it acting. Assess contraindications and adverse effects of both methotrexate as well as cyclosporin. Now, with regard to systemic steroids, we have to be careful. We have to be very, very careful, particularly when using systemic steroids in children because of the known side effects. Caution with use of broad immunosuppressive in the age of COVID-19. I would like to put this up here. Now, what are the goals of what we call as precision medicine? Efficacy, time. We have to look at these: time of onset of action, accessibility of a molecule, the safety of a molecule, tolerability. That's what we call as precision medicine. What to precisely use and how to use it. Topical agents recently, particularly in the Western world, not in India, we never ever can afford to use crisaborole because the cost of it is so exorbitant. However, in the Western world, they feel crisaborole and pimecrolimus and tacrolimus will be helpful in a big way, and they are the mainstay of AD treatment. But crisaborole is, first of all, not available in India, and secondly, even if you can get it from the neighboring countries, it's very, very expensive. The risk of cancer with the topical calcineurin inhibitors, because when you're trying to optimize, want to give the best to the patient, they should be prepared to look at the downside of any molecule. All the while, I was telling you tacrolimus is good, but let's look at the downside. Initially, when tacrolimus was initiated into the Indian market, I also used it earlier, very, very early, about 30 years ago. I started using tacrolimus. I never ever noticed any side effects. Whereas Western literature definitely say that certain children can develop certain forms of malignancy. However, the conclusion of those studies is no evidence was found that topical tacrolimus increases long-term cancer risk in children with AD. That is the final outcome. Therefore, one can use tacrolimus or pimecrolimus liberally without any fear. And again, looking at the optimizing factor, what is the unmet need? Keeping patients clear of AD flares safely. That is very important. They should not have flares and they should still remain safe. So for that, a proactive therapy approach. Now, what is meant by a proactive therapy approach? Even when the patients are normal, they will have to be visibly normal, they will have to be treated. Importance of avoiding stinging, burning with topical agents. Again, trying to optimize outcomes, optimizing the treatment. It's uncomfortable for patients. It leads on to loss of trust by the patients, loss of therapeutic alliance opportunity. Why? Why are they not adhering to treatment? Why are they not treatment compliant? No? You don't use the word non-compliance. We use the word that they are non-adherence nowadays. So how do we fight that? And how do we try to optimize that? Try a test area first. Again, what is advised in Western literature, crisaborole and TCIs, which we cannot use here. Maybe you could use TCIs or topical corticosteroids themselves, test areas. Now here is another huge big molecule, dupilumab. Dupilumab, available in India, but again, very, very expensive. I have not used it, honestly. I have not used it so far. A lot of ongoing open label studies are there where they give 300 milligrams every 4 weeks. And that could be titrated up in the case of inadequate clinical response. 300 milligrams itself is very expensive. You're going to titrate it up, it's going to be more and more expensive. So that's not optimizing at all. That's not optimizing at all. Of course, the comorbid conditions that are known to be associated AD, again, comes to play an important part when we want to optimize the outcomes. Unless and until we know the impact of atopic dermatitis on the quality of life of children who suffer from atopic dermatitis and the family members. My colleagues and I did a study on that, atopic dermatitis impact on the quality of life of family members. Found the parents were always suffering from guilt. The siblings were always suffering from thought that they were being restricted from certain forms of food and certain form of activity because one child could not go out and play. The other child was also prevented from doing. So for no fault of theirs. Apart from this, the comorbidities that could occur. The obesity, which could be really morbid. You find many children, morbid obesity coming with atopic dermatitis. Adults coming with cardiovascular events, coronary artery disease, angina, myocardial infarction, stroke, cerebrovascular disease. Cardiovascular risk, number one, hypertension, dyslipidemia, prediabetes, type 2 diabetes. And finally, behavioral factors. Now, these behavioral factors, that's what I said, is the quality of life getting affected. I used to have a slide saying, if I don't sleep, nobody else sleeps. That's the type of feeling a child gets, It's very, very difficult to treat that. And to optimize that in terms of outcome of a treatment is almost impossible, The next thing is the risk of infection. I told you antimicrobial peptides are affected. So different types of infections. Ear infection, strep throat infection, urinary tract infection, pneumonia. Different odds ratios are seen. The ORs are different for each type of infection. With the goals of therapy, precision medicine, which I spoke about earlier, reduce the number and severity of the flares, reduce pruritus and improve quality of life, maintain normal activities of daily living, maximize disease-free periods, prevent infectious complications, minimize side effects of treatment. So that easily said to optimize the outcomes, treatment outcome. But the most important factor there is that one should be prepared to be proactive, not just reactive. When the eczema comes, immediately apply a steroid. I apply an antibiotic, give an oral antibiotic, and then after that, forget about it. That's not the way. The doctor as well as the patient's parents should be advised about this proactivity. Now, key recommendations with the level of recommendation, moisturizers, bathing, followed by moisturizers, limited use of non-soap cleansers. And this is something which is important. Quite a few practitioners start advising these non-soap cleansers, talking about low pH, 5.5 pH, that, which not always necessary, and not always necessary for everybody. Now, what about the addition of oils, emollients, and other additives to bath water? I find patients come and say, I add Dettol always to the bath water. Useless, absolutely useless. Don't ever allow the parents to do that. Don't ever allow the patients to do that. Absolutely useless. Adding eau de cologne, adding some other antiseptic. Never ever do it because it's totally useless and waste of money. Now, this would be the therapy triangle, optimizing treatment outcomes. Three things. Moisturizers, first and must, all the time, moisturizers. Anti-inflammatories, topical steroids or topical calcineurin inhibitors. Antimicrobials, usually given orally if necessary, can be used topically. When I say antimicrobials, doesn't mean only antibacterials, could mean even antivirals sometimes or antifungals also, depending on the situation that is looked upon. Now, what is A-rated evidence-based approaches? Again, use of moisturizers, topical steroids, topical calcineurin inhibitors, against the routine use of topical anti-staphylococcal treatment. That's important. Fine practitioners giving a thick wide of prescription for antibacterials, particularly anti-staphylococcal ointments and creams. The child has been using cartloads of them. That is not at all necessary, and that's wasteful exercise. Skin hydration becomes very important, and immediately after hydrating, that is immediately after pouring water onto the skin, use a gentle cleanser and immediately apply an emollient. The general recommendations: warm water, not hot water. Warm water, bath better than shower. A bucket and a mug can be taken and poured onto the child just for 5 to 10 minutes, not for longer. Neutral, low pH, hypoallergic, fragrance-free, non-soap cleansers preferred. The non-soap, we always talk about surfactant-based cleansers. That's good always, surfactant-based. Bleach baths are now standard of maintenance care for pediatric, moderate to severe, but we must know how to do it correctly, because if we add more bleaching powder, the child could inhale it and go in for a wheeze. Trigger avoidance, best way again to optimize treatment, identify, eliminate trigger factors, which is very, very, very difficult. But of course, avoidance of the common triggers. Not so much the soaps and detergents, but wool, yes, and occlusive fabrics should be avoided. Contact allergens, fragrances, preservatives. Recommend control of temperature and humidity. Don't use heaters in the bedroom. Avoid use of heaters, as a matter of fact. Consider possible allergy triggers. Skin tests. Although skin tests, I must tell you, are poorly predictive of triggering factors. I must tell you at this point of time, in my humble opinion, these skin tests are the singularly most unuseful tests. Then allergy because after we find that out, then keep on giving immunotherapy, which again is endless and useless. Limited data regarding the benefits of leukotriene inhibitors. Leukotriene inhibitors are found to be effective. First, if you're thinking in terms of using montelukast, there's one molecule which is being used. A montelukast is very useful, but useful only in certain situations. Suppose if you take up individuals with urticaria. Now, if the urticaria is atopy associated, you can use montelukast. If the urticaria is associated with aspirin intake, you can use montelukast. If the urticaria shows positivity to autologous serum skin test, you can use montelukast. So these are the three situations when montelukast can be used safely in patients who are having urticarial wheals. Otherwise, these leukotriene inhibitors are not found to be useful. Patient education, big time, easily said word. Educate the patient, educate the family, show them the different ways of using the techniques that you would like to think. And patient and family quality of life often impaired, as I told you earlier, our studies have shown. Now, what is the reason for the patient not being compliant? As I told you, we no longer use non-compliance, we use non-adherence. Why? Poor motivation, secondary gain, lack of trust in the doctor, fear of medication, don't know what to do, burden of treatment. This is the most important. The financial burden, and also the perceived burden, passing the responsibility back from one to the other, forgetfulness, laziness, resignation. Now, these are some of the things which the patient has to be counseled about. Specific strategies to promote adherence. We're told what are causing the adherence. How are we going to promote adherence? Build trust, simplify the treatment. It's very important. Don't complicate. Don't say you put this for 5 minutes, wash it off, put another for 10 minutes, wash it off, another for 3 hours. I've heard this. I'm not joking. I've heard people say this. The whole day through, they are applying something or the other, which is not necessary at all. Now, let's look at the implications of clinical practice to optimize treatment outcomes. The Western world is always talk about dupilumab, but dupilumab is always giving a rosy picture. The presence of iritis, hydrocyclitis, conjunctivitis is also seen. Systemic corticosteroids, one has to be careful because of the side effects, because it's an index therapy. in 3/4 of patients is always increased. The higher rate of persistence with dupilumab suggests that patients are more likely to receive treatment with dupilumab, which has strong evidence to support its use than other medications. For instance, cyclosporin, methotrexate, azathioprine. It all depends how well your patient tolerates the particular medication and how well one is able to advise it for clinical practice. Now, what about the takeaways, my dear friends? Now, many in development and new treatment options for patients with AD are available. New studies and research bring awareness about AD. Any of you can do new studies and research. There are so many associations and societies willing to help you out in this type of research. Patients with AD have different individual needs. That's one thing is of prime importance. There is no one-size-fits-all treatment. The newer one, JAK inhibitors, tofacitinib, is one thing unique and can help meet some of the unmet needs. So I use tofacitinib for atopic dermatitis and found it to be useful. Dupilumab, as I told you, I've never used this or crisaborole so far. So important for patients to practice good basic skincare and avoid triggers. And that would be the biggest takeaway that I would like to give all of you today. In other words, there are only three magical terms: safety, efficacy, and economy when we look at optimizing outcomes in the treatment of atopic dermatitis. Thank you very much for your attention.
Thank you so much, sir, for such an insightful lecture. We have a couple of questions for you, so I'll just read them out for you. The first question is, what role do probiotics play in the treatment of atopic dermatitis?
Probiotics, I did not want to touch them here today because I'm talking about it on Saturday again. It's a good question, and probiotics do play a role. Because when we talk about probiotics, we're talking about something which will have an effect on the dysbiosis. Dysbiosis is the bacteria about antimicrobial peptides that affect. Now, when antimicrobial peptides affect, it is only correct that we are able to correct this dysbiosis on the surface of the skin. But then we can't go and use a probiotic on the skin. You have to use it only orally. So it has been found that what is happening on the surface of the skin is almost similar to what is happening in the gut mucosa. After all, the mucosa is a continuation of the skin. So that is how probiotics are helpful.
Sure, sir. Another question is regarding what forms of non-medical treatments are used to treat atopic dermatitis?
Non-medical treatment will include, first of all, counseling. Number two, good soap and detergents, which are found to be useful for a particular way. There's not one size fits all. No? Then the type of water, the type of aeration, the housing comfort, then the quality of life and lifestyle modification are a few things that we can look at.
One more question. So, are there any gender-based differences in the prevalence of atopic dermatitis?
Now, as long as we find it in children, there doesn't seem to be any gender difference. But for some unknown reason, as they grow older, males seem to be affected more than females, at least twice as many.
Is there any particular reason, do you think, why this must be happening?
No. I'm not able to really figure out. I would have told you right away. I'm not able to figure out a reason for it.
Okay. Also, sir, in regards to diet, any food items that should be avoided, when a patient is suffering from AD?
Certainly, food that the child is not able to tolerate, he or she should avoid. And that is only by trial and error method. You cannot give a long list of items and just give up everything, because that is one thing or rather two things that the patient asks before leaving the consulting room. One thing is, forgotten, rush back and what soap can I use? I say, okay, you can use this. Goes again, he rushes back. What can I eat? Trust me, recently there was a mother who said, I told, avoid mangoes if he is not accepting it and he is allergic. Also, then all of us should avoid mangoes. I said, yes, all of you avoid. What else will you have to do? That's a very, these are types of people we have to deal with, we are forced to deal with.
Sure. So I think that's all the questions. So any closing remarks from your end?
My end, I would just tell everybody to look at atopic dermatitis in a proactive manner. It is not something which you can cure. It is something which you definitely bring under control. Be prepared all the time. Abundant use of moisturizers. Moisturizers.
Thank you so much, sir. Thank you so much for making time to speak with us, Dr. Thomas. So glad to have you as an expert faculty today. All of us in the Docplexus team and all our doctor members from our community deeply appreciate and value your insights. I wish you a safe and a pleasant evening ahead. We hope we can connect with you sometime soon again. And also for our great viewing doctors members, thank you so much for tuning in on behalf of the Docplexus family. Thank you for being such an amazing doctors in this tough time for your patients. Hope you and your family stay safe. Please continue to support us and log in for daily dose of latest news, webinars, and news guidelines on our platform. Have a great day ahead. Thank you so much, and please be safe. Thank you, sir.
Thank you very much. Stay home, stay safe.